Good afternoon, everyone. Welcome to the Wake Forest University Center for Artificial Intelligence Research, Artificial Intelligence in Action seminar series. I'm Metin Gürkan, Director of CARE, and it's especially meaningful to host today's seminar as part of our Nurses Week celebration. My mom was a nurse, my wife is a nurse, and it's especially meaningful for me to celebrate the Nurses Week with a talk on AI research. And it's my pleasure to introduce Dr. Sarah Rossetti, Associate Professor of Biomedical Informatics and Nursing at Columbia University. Dr. Rossetti's research focuses on clinician-driven, human-centered AI solutions that improve patient outcomes while reducing documentation burden and clinician workload. Her work has been supported by organizations including the NIH, ARC, ONC, and the American Nurses Foundation. Dr. Rossetti co-leads the CONCERN Early Warning System study, an innovative nurse-driven AI model that predicts patient deterioration using patterns of nursing surveillance. This work has demonstrated significant improvements in patient outcomes, including reductions in mortality risk and sepsis, while also supporting more timely escalation of care. Today, Dr. Rossetti will discuss how integrating nursing expertise into AI design can help create more effective, trustworthy, and human-centered healthcare technologies. Her talk will highlight the importance of modeling real clinical workflows and nursing decision-making to ensure AI systems reduce burden while improving care delivery. Please feel free to submit your questions in the chat. We'll address them following the presentation. With that, please join me in welcoming Dr. Rossetti.
Thank you. Thank you so much, Dr. Gürkan, and I'm thrilled to be here for Nurses Week. So I'm going to share my screen here, and you should see that. We'll put it in presentation mode. Okay, great. So I'll be talking about nurse-driven, human-centered AI and opportunities to improve patient outcomes and decrease burden. I'd like to acknowledge the many wonderful people that I work with on several different research studies, which have quite large research teams across several different sites and the funding that we receive, as well as thanking the nurses who have participated in each of these research studies. So I'll be talking about the CONCERN early warning technology a little bit later in the talk, and we do have a non-provisional patent application for it. So learning objectives, these are them, and I think I can share them otherwise as well. So right now is quite an interesting time for nursing and AI. I think both of them in general. If you have been reading the news over the past, even just the past year, there's been quite an increase in discussion around nurses and AI. So AI enters the exam room. We certainly have seen nursing strikes and the incorporation of AI as a concern within some of the other concerns being voiced there. We have Nurse Avery, a Google-backed AI nursing assistant that launches in 10 health systems. In Washington State, if you've been following, there's a legislation that, sorry, AI, you can't call yourself a nurse. So distinguishing that a nurse is a human. We have artificial intelligence lightens administrative burden on nursing, and aiming for sustainable change in how AI tools at UCSF is one example in streamlining nursing workloads. So seeing some of the negative press, but also these examples of how AI may help to decrease documentation burden for nurses. And then more recently, some discussion around nursing in the economy, that the most valuable worker in the AI economy is Nurse Dana from the Pit. The nursing boom grows as AI reshapes the workforce and healthcare demand rises. And nursing is the surefire new path to American prosperity. So, a lot of kind of dynamic news, a lot of news about AI and a lot of news about nursing. I like to take a step back and reflect on some of the reality of where we are in clinical nursing at the moment. And so this is actually a scoping review that was published by Rachel Lee, who had been a postdoctoral research scientist with me, and found that only 9 studies reported a statistically significant relationship between required nursing documentation and patient outcomes. Just like to reflect on that, of all the literature out there of the requirements for documentation. And so we're not talking about care processes and evidence around nursing care and the nursing process here. We're talking about when you require a field to be documented, do we actually have evidence that there is a need for this because this influences patient outcomes? And there is really a lack of that when we talk about required documentation. In the past 15 years, the percentage of time nurses spend documenting has increased from 9.5% of their shift to just over 30% of their shift. Substantial. I lead AMIA's 25 by 5 task force. This is a national task force on reducing documentation burden, and AMIA is the American Medical Informatics Association. The AMIA and the task force are focused on all health professionals. And we put out this paper here led by Deb Levy that defined, because there wasn't a good definition of documentation burden. And actually we found it really identified this definition, that excessive documentation burden is defined as the stress and unnecessary heavy load or work a healthcare professional or healthcare team experiences when the usability of documentation systems and documentation activities are not aligned in support of patient care delivery. You see that QR code there. If you are willing and have a moment, please take that survey. It is the Trend Burden Survey. It is 6 items long. It is intentionally very short. And it's to trend documentation burden nationally. And we're now sending it out annually. So it's now live for the next month. It previously had 5 questions. We added an AI question. And still keeping that QR code up if you are willing to take it. We've actually been sending this survey out for just about the past 2 years. And previously we did it every 6 months. We're now doing it annually. But we haven't actually seen improvement. And so this is the perception of documentation burden by all clinicians, all health professionals that document in the EHR, I should say. And the nursing results are the same in that from a statistically significant point of view, they haven't changed in the past 2 years. So, and there have been several efforts to reduce documentation burden, but it's almost as if we're seeing a little bit of a pause in the actual results of those efforts, or perhaps those efforts. So I wonder, are we waiting for AI to solve these problems? Some clinical nurses' perspectives on AI, and this is from a study that I lead funded by ONC, Office of National Coordinator. You can't replace nursing judgment and nursing experience. So yes, AI to me is welcomed in this field, but I think it shouldn't be the end all and be all. There should be some built-in component for clinical judgment because you're at the bedside, you're laying eyes on the patient, and I think that's paramount. So seeing this as a continuum of the idea of being fully automated without some human involvement really scares me. 2, I feel cautiously optimistic is what we heard from a national sample of nurses. So where are some opportunities for AI to reduce burden reduction? Well, this is kind of how I see it, that again, on a continuum, you could have AI systems that are fully automated and that fully complete a task. Now, what tasks should these be? Administrative tasks that are not part of professional nursing practice, and there are many. So for many years, to get some things done within the hospital, a human needed to do it. And the truth is that often that defaulted to a nurse. And so if you look at the items that nurses are charged with doing, there are many administrative ones that we can look to AI to fully offload. And I use the example of patient belongings. And I use this purposefully because you can imagine, do we in the near future still need the nurse to itemize the patient belongings and document those patient belongings or be responsible for, this whole process? could we have robots that come up and do that? And that might seem futuristic in some settings and maybe not in other settings that have implemented similar types of automation, but why not? And let's look at those items that really are not a part of professional nursing practice. We also have this part in the middle where we can semi-automate. And so, for example, where AI completes the documentation of a task, but the nurse is still completing that professional nursing practice. An example is turning the patient. The nurse going in to turn the patient is doing a very important assessment of the patient's skin, as well as, probably conducting some other assessments at that same time. But the documentation of it is excessive. And so let's offload that task and even look at what types of ambient listening technology or computer vision technology can we use to capture that, or sensing from beds. And then there's clinician in the loop. So where the AI guides the nurse's reasoning or subsequent actions. This could be intelligently filtering patient level information from our EHRs, which have a lot of information overload, contextualizing information to that patient's current condition, or helping to prioritize information that then the nurse makes the decision for patient care. I think also really important to reflect on the types of AI that we're talking about. And this is evolving. So a year ago, I didn't have these last two components on the slide here, but we have traditional AI systems that are prediction and classification. And so those are, reactive or narrow and well-defined for a task. It just predicts what, it is that it was programmed to predict. And then we have generative AI models that create novel outputs, but there's still the user that has to initiate that and prompt, for instance, with ChatGPT. That's an example, prompt for an output. Then we have what's evolving here with AI agents, where they can actually they can be charged with a specific goal or task and autonomously and initiate on their own that the work towards that. And then agentic agents, which are actually even more autonomous and may not have as well scoped a task, but a broader goal-directed behavior. I think important to acknowledge these. While they're not really in clinical practice right now, they are in development and testing. And so we don't know exactly what that runway is until they are in clinical practice or being, actually tested in clinical practice. But from a nursing perspective, I think it's really important to see what is being looked at that could be implemented in clinical practice. And we'll talk about why in a moment. So what is human-centered AI? Well, it prioritizes well-being, ethics, and values of humans. It's designed with awareness that it is part of a larger system. The AI is aligned with human values and goals and focuses on amplifying, augmenting, and enhancing, not replacing, human performance. I think I, as a clinical and nurse informatician, I kind of live and breathe around these types of concepts, but I think it's really important to have a concrete way to conceptualize what this is. And we're going to talk about it and then how that becomes operationalized. And so the best way I've found in talking to audiences that run a breadth of types of experience, whether that's computer, science experience to clinical experience, is to reflect on this quote. It's not the critic who counts, not the person who points out how the strong person stumbles or where the doer of deeds could have done better. The credit belongs to the person who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs and comes up short again and again, because there's no effort without error or shortcoming, but who knows the great enthusiasms, the great devotions, who spends themselves in a worthy cause, who at the best knows in the end the triumph of high achievement, and who at the worst, if they fail, at least they fail while daring greatly, so that their place shall never be with those cold and timid souls who knew neither victory nor defeat. A famous quote in the arena. And who's in the arena? The nurse is in the arena. The patient is in the arena. The physician is in the arena. The nurse practitioner, the PA, the respiratory therapist, the family members and caregivers. So the patient, the family, and all health professionals who are actually in the arena. Those are the ones who can say what is then human-centered. Knowing and respecting the arena brings clarity to that human-centeredness of AI. And especially as our tools become more and more sophisticated, this is something from a conceptual point of view, we have to remember what that human-centered part of it really means. Nurses coordinate many invisible activities and decisions in the arena. And these invisible activities and decisions may in the future risk patient safety with innovations such as agentic agents. And we'll talk about that in a bit. Now, in terms of operationalizing human-centered AI, there are frameworks that are out there and guidance that's out there. But there's often a gap between the actual implementation from those frameworks. But it's really important to understand that they are out there. And this is one example from Kai. And this is just one excerpt from their Core Principles for Trustworthy Health AI report. And this focuses on the design of an AI system. And I'm just calling out a few things here. So it's recognized that these requirements and principles are out there to abide by when designing human-centered AI, or when nurses are then faced with the implementation of an AI tool to really be able to speak to or ask questions about, is this human-centered? So fairness, that ensures real-world outcomes are fair across all groups, that ensures stakeholders review and approve implementation processes, ensures users can control and override AI recommendations, ensure the AI system allows for human oversight and intervention, and ensure documentation considers end user knowledge. Why can't AI models and agents just use standards of care in institutional processes and protocols when, in terms of their inputs in design? How could that fail? Well, for nurses that are, in the audience here, have you ever thought of, in making a clinical decision, which of these questions will you be faced with? Why didn't you use your clinical judgment? Or why didn't you follow the protocol? Because sometimes in clinical care, the protocol is not enough. Protocols are linear. We have an example here, and we'll go into more details in this example, of a glucose check, administering insulin, and then the patient eats their meal. Now, for patients that get insulin in the hospital, this occurs multiple times a day. Nurses are doing this process multiple times a day. Within our documentation, and the protocols themselves look quite linear, but clinical care is not. AI models can't assume that missing data equals missed care, and we'll talk about some of those examples. Sometimes holding the insulin might be done for patient safety reasons. And so this diagram is actually a knowledge graph that we've built out as one of our studies funded by the Office of the National Coordinator. And the purpose of the study is to formally represent important aspects of the nursing process that are not captured or would limit the quality of data that's an input to an AI model. And so what you see here in red are important concepts and decisions made by nurses that are not represented in the EHR. And we created this knowledge graph based on interviews and focus groups with national sample of nurses. So let's walk through this a little bit. So here's the simplified version, on schedule and per protocol, and taking out some of the additional concepts in here just so we can focus a little bit better. Hour 1, the patient's blood glucose is normal. Hour 2, their meal is delivered on time and the insulin is administered by the nurse. Wonderful. Example 2, the nurse needs to intervene. So hour 1, their blood glucose is normal. Hour 1, still the meal has not arrived. And so still within hour 1, the insulin is not given by the nurse because the meal hasn't arrived yet. Hour 2, the meal still has not arrived. And so the insulin still is not given by the nurse. And at that time, the nurse decides to give some crackers. Hour 3, the meal finally arrives. The nurse rechecks the insulin. It's trending out of range. The insulin is then administered by the nurse because the meal is there. So that was a process that nurses often take to prevent hypoglycemia. Here, let's extrapolate a little about a potential risk of this process that occurs in hospitals multiple times a day, every day, potential risk that could be introduced with an agentic agent. Hour 1, the blood glucose is normal. The meal still has not arrived. The insulin is not given by the nurse. The meal has still not arrived in hour 2, so the insulin is still not given by the nurse. Crackers are given. An agentic agent that's tasked with this broad goal of decreasing length of stay escalates a recommendation to the resident to give insulin in compliance with the protocol. Now, would this happen today? Unlikely that a resident would administer insulin in this capacity. But with an agentic agent, it's possible you could imagine a situation and when then a resident administers that insulin and there's a critically low glucose. And so these are things that we have to understand. The nurse is making many decisions that are not represented in the EHR. And if agentic agents are then built on top of that, we have to be very aware of what is it that the agents do not know. And so our team has put out this paper, and here's a QR code to it. It's a preprint. And so we're actually seeking input on this paper because we want to make it as best we can from the nursing community to inform the data science community really about important information about nursing data and how it needs to be understood as inputs to AI models, and then how it needs to be interpreted as well, in the context of those outputs. And so welcome any of your feedback there, and then we will be submitting it for peer review once it's ready. And so I'm going to switch gears a little bit now and talk about the Concern Early Warning System. It's an AI-driven real-time early warning system for patient deterioration. So when you look at the electronic health record data, certainly for any clinicians on the call and anyone who's queried data from, the other end, the EHR databases, there's a lot of information a lot of data in our EHRs. There's a lot of excessive documentation requirements. We already talked about that a bit. And there's a lot of recording of standard of care. I think some efforts have been successful at institutions over the past several years to kind of take some of that out. Some of those required documentations that are just asserting a standard of care was done, but it still does remain. And the fact is that data looks the same for all patients. And so it lacks a statistical signal. And so, but there is good variability when you look beneath the surface. And so I use this kind of flipped iceberg, visualization to kind of convey this. The signal is strong, but you have to know, how to look for those signals. And so we've looked at nursing surveillance patterns. And this really aligns with the nursing process, which is the diagram you see at the bottom there. So what we've found over many years, actually the Concern study has been going on for about 15 years now, funded by NIH for 10 years. And then we've also had funding from the American Nurses Foundation for about the past 5 years, or 4 years, I should say. And I've been leading the Concern study with Ken Ricato, this entire time. And so what we've found is that there are temporal patterns in the EHR that reflect a nurse's concern. And these are patterns in which there are entries with increased frequency and entries done at uncommon times. And when we model that, we can actually predict patient deterioration 2 days earlier than other early warning scores that use only vital signs or lab data. Vital signs and labs, physiological data essentially is a late indicator of deterioration, because once those change, by definition, you're already deteriorating. You're in that deterioration state then. And it's much harder to intervene effectively. But nurses identify these subtle cues of patient deterioration much earlier, and based on our data, up to 2 days earlier. And when they start to identify those subtle cues, they change their behavior a bit. They start assessing the patient more frequently to identify if this is a concern that they need to escalate care for. So to confirm what that concern is and to see if further interventions are needed. And the example of uncommon times is important there. So there are many things that nurses do at scheduled times. And then when something is done at that unscheduled time, that can be a very strong statistical signal. And so the increased frequencies, we look at increased frequency of vital sign documentation or comments documented within the EHR, or increased frequency of notes just being written. So this is metadata, and we're looking at those date and those timestamps. And the uncommon time, an example is in the acute care setting, if a patient that should otherwise be sleeping through the night, if a nurse is going into their room at 3 a.m. and checking, all of their vital signs, well, why? Probably because that nurse is concerned about that patient. Why wouldn't the nurse be letting the patient sleep otherwise? And so we actually model out these common versus uncommon times in our machine learning based model, as well as the actual frequency of nursing documentation patterns. We also include other things such as the day of the week, the hospital day for that patient, whether it's a day or a night shift, what season is it? These are all things that have important signal within them in terms of the nurse's documentation patterns. And we've found that we can model patient deterioration, like I said, about 2 days earlier with high accuracy. And so I should say here, what you see is that we built it into a real-time clinical decision support in the EHR, and it's the way that we've built it in our design so far and implementation so far is that it's viewable in the patient list as a red, yellow, or green icon, and there's an asterisk next to it if the score changed in the past hour. So we run the score for every patient every hour. And so just that information is typically enough for the clinician to see. And so what we're really aiming at here is increasing shared team situational awareness of this patient's level of risk. And we completed a lot of user-centered design sessions with nurses, physicians, PAs, and MPs. And we're really aiming to increase that awareness, team awareness of these yellow patients, understanding that the red patients are probably already identified by the team. And so we conducted a multi-site pragmatic cluster randomized control clinical trial at 4 hospitals, which was across 2 health systems. And this was a total of 74 clinical units. We randomized at the unit level. So some of the hospitals some of the units in each hospital were concern intervention units where those clinicians, that care team, could see the concern score, and some of them were the control, the usual care units where they could not see the concern score. And this was just over 60,000 patients. And what we found was a decreased risk of mortality by 35.6%, a decreased length of stay by just over half a day, a decreased risk of sepsis by 7.5%, more timely ICU transfers, and increased cost savings. And all of these were for patients whose care team received the concern early warning score versus the units in which the care team did not receive that score. And this was published a year ago in Nature Medicine. Now, we then, after that trial was completed, we then had data that we could look at in terms of a sub-analysis to say, well, what was going on with those ICU transfer patients? Because we actually saw an increased, about 24% increased increase in ICU transfers. And as it turns out, so now we have a deterioration score that we have hourly data for. Previously, it's really hard to measure deterioration. You have your outcomes, you have sepsis, you have mortality, you have cardiac arrest or ICU transfer, but that's the outcome. That's not the actual deterioration process. So we now had hourly scores, so we could start to model out the deterioration process. So we looked at just the intervention units, and we looked at when the score first changed from green to yellow or green directly to red, and then how long did it take to transfer the patient to the ICU for those patients that were transferred to the ICU. Because we wanted to understand what was going on with the ICU transfers. Is this a good thing or a bad thing? And clinically, any clinicians on the call would probably recognize what the difference is between an early transfer and a late transfer to the ICU. Interestingly, in the literature, there's not much written about it, I think because it's a hard thing to measure. And so what we found is that all patients who died were transferred more than 36 hours after the score change. So they were a late transfer to the ICU, the patients that died. So each 1 hour delay of an ICU transfer increased the odds of death by 28%. So essentially in our data, we increased these earlier ICU transfers, and those patients went on to have better outcomes. In our concern model, we also, in its design and development, focused on AI fairness, which is incredibly important. What we did is we looked at the outputs of the concern model, and we looked at the outputs of other early warning scores, such as the National Early Warning Score and the Modified Early Warning Score, because those really were the leading scores at the time we did this analysis. And we looked at it for by race to see if those outputs were different by race. So for Black or African American, compared to white or Caucasian. And we saw that there were statistically significant differences in outputs across all three of the scores. We know that there's bias within EHR data, and so it is not then surprising to see then the bias come out on the output side. So you should expect that if there's bias on the input, there's bias on the output. So what we did before implementing is we mitigated that bias for the concern system in terms of what we had observed there, so that the output did not have a statistically significant difference between populations. We also saw this for primary language. And so one important aspect of our model is it's the frequency of documentation, and we include in that the frequency of a free text comment being documented and by nurses in the flow sheets. And so what we found is that that for patients whose primary language is English compared to patients whose primary language is not English, there was a statistically significant difference as well in the frequency of those comments. And so really important to mitigate any bias in terms of building a model with fairness in it. And I want to emphasize that this is an area that is still really important to scientifically get right. And we're just starting here. And so this is evolving, and more work certainly needs to be done. Just a couple notes on the actual development of the concern early warning system. So we were really intentional that it would not increase documentation burden. So there was no way we were going to build a pop-up. And there was also no way that we were going to require the nurse to document anything extra. And so all of the data feeding into the model from the get-go was something that had to already be available in the EHR. And then we work closely with end users, nurses, physicians, NPs, PAs, to design the actual screens that they would see. And so, we went through many iterations you see up on the top left there, one that we of course, would never deploy in the actual EHR, but just working through what is it that clinicians want to see, and landed it on this kind of 3-point scale of red, yellow, green as enough information. And then what you see at the bottom there is this detailed screen. So if a clinician wants to double click on the red, yellow, green icon, they can. And then they can pull up information about what data from the EHR was actually driving the prediction, and what factors, or features within the model did it align with. And then what has this patient's concern score trend been over the past 72 hours? And then where is this patient compared to other patients on the clinical unit? So our concern models have actually been shown to be reproducible and generalizable. So colleagues from the University of Utah published this paper that you see in the bottom left corner there. It was actually an independent validation of our model, and it was actually a less advanced version of what we had then tested in our clinical trial. Which was interesting in a few ways, because it showed to still perform very well on this large public data set of over 200 adult ICUs. And so it was using the eICU collaborative database. They applied our model. And it was shown to still have good predictive performance and to um, um, to work well in a generalizable way across that population of hospitals. And I'll note that the concern early warning system is for both acute care as well as ICU. In this case, they just had that public data set of ICUs. We also have implemented at a rural community hospital in Martha's Vineyard, and then we found it important to work with nurses to do a really detailed chart review to see their agreement with the concern early warning score. Because this type of implementation, there are different types of decisions that are made for a deteriorating patient when you're in a community hospital, where in this instance, actually, they need to be flown off island for some types of escalations of care. And so that was an important type of process that we did. So we're currently scaling and spreading the concern early warning system. And so American Nurses Foundation has funded us to build an implementation toolkit. This is online and available, and all of the resources needed to implement concern are in there. Everything from the PowerPoint that you need to talk to your hospital executive and kind of pitch it to see if they're interested, to some of the technical documentation, to some of the slides or resources that you can use for training end users when you are ready to implement. Now, everything's on there except the actual software, that if there is a site that is very interested in implementing this, we would be happy to discuss further and then enter into an academic research license to do that. And then what you see on the side here are the places where we have had funding to scale and spread concern. And actually, the Perinatal Research Consortium, I'll just point out, that is all data science work. We're not implementing something, but what we're doing is looking at this modeling approach for the inpatient labor and delivery stay to see if we can also predict deterioration outcomes for those laboring moms. And then we're also expanding to children at Children's Hospital Colorado, building out a pediatric version of the model. We're actually additionally looking to see how we could incorporate family input to that, because who better for a child who's hospitalized to identify concerns about their state than their parents or other caregivers. So kind of, in summary of the concern discussion here, it really has demonstrated that nursing surveillance saves patients' lives. So what is nursing surveillance? It's a systematic process that includes pattern recognition, anticipating problems, coordinated communication, and decision-making to identify patient risks, escalate care, and prevent harm. It was previously thought to defy empirical measurement in and of itself, and it's often not understandable or recognized by non-nurses. I think of this as invisible nursing care, really, which has been defined. Invisible nursing care as a gap between the work carried out by nurses and the work of nurses that's understood and acknowledged. Some may then even go further, and we've published on this, that it could be a type of hermeneutical injustice, which, if you think of that's not understanding what it is that expert knows and does. And so when you don't understand or recognize that, we have situations, for instance, when hospitals add tasks to nurses' workload, when it looks like maybe what they're doing, when it looks like maybe the nurse has additional extra time, or if we remove some documentation burden from a nurse and all of a sudden we think they have more time, we just add more tasks and more task-based responsibilities that are not aligned with their primary professional responsibilities, such as nursing surveillance. So we've posed this question. Imagine you visit the local pool brimming with children of all ages and observe that the lifeguards are busy with electronic documentation, even while in the lifeguard chair. When you ask why, they say that the pool executives have decided the lifeguards are mostly just sitting around, yet are so knowledgeable about pool operations that it would be a better use of time and money to have them be responsible for additional tasks needed to manage the pool. Would you raise the alarm? Now, I'm a former lifeguard myself. I'm also a former critical care nurse, and I have 2 young kids, and definitely I would raise the alarm at that pool. Nurses may make surveillance look easy to put patients at ease, but there are costs to unprotected time for invisible actions that save lives. So we've put together this diagram, and in my mind, it really isn't, it's not just about the concern early warning score. It's about nursing surveillance. It's about why concern works so well. It's because nursing surveillance, can influence all of these things. We built a score that's based, the input to the AI model is based on nursing surveillance. So we were able to increase shared team situational awareness, and we were able to identify and mitigate biases and lead to earlier transfers to the intensive care unit, reduce mortality and sepsis, and reduce length of stay overall. And so we can use this example as a way to recognize the importance of nurse autonomy, that we couldn't have had these inputs to the concern model if we didn't have nurses performing this incredible decision making for patients in terms of the nursing surveillance that they were engaging in, and recognizing then the nurse agency to then use these scores and increase team awareness and escalation of that. And I think we need to start recognizing nurse empowerment, and that we're building this, level 1 evidence of what nursing surveillance is. We do, and it's not just nurses, it is physicians, it is all health professionals are faced with a wicked problem in our healthcare system of clinician burden and burnout. There's this framework here is from the American Nurses Informatics Association, ANIA. And this framework was published quite a few years ago, and it works very well to understand this problem of documentation burden, that we're faced with poor human-computer interaction design. We have a lot of reimbursement, regulatory, and quality requirements. There's a lack of interoperability still within our systems. These EHRs present a lot of information overload. And there are problems with organizational culture and compliance, that we overbuild our EHRs in order to make sure we're compliant with some of these regulations, but we overdo it. And we've actually, through the 25x5 task force, had discussions with Joint Commission who are saying, yes, it's overinterpreted how these things are implemented. And so that is placing excessive burden. So we've actually looked at nursing flow sheet data. And this is a social network analysis of nursing flow sheets. In one EHR, it is overlapping, it is large, and it is complex. And so this actually, some flow sheet templates have almost 1,000 flow sheet measures on them. And then flow sheet measures can be redundant across all of these different templates. And they were built that way originally. So let's reflect on why they were built that way. Well, they very much still reflect paper-based flow sheets. So we essentially computerize paper-based flow sheets. We haven't changed that technology or innovation almost at all since we did that. But then we kept adding data elements to each flow sheet, because we said, oh, okay, so we want to make it more usable for the nurse. And so let's add all those data elements that they might want to document if they're in this flow sheet, and then all the ones over here in this flow sheet. Now, there have been efforts to reduce the data elements overall in flow sheets and change the design a little bit. Not really change the design, but change maybe the volume of information on them is how I'd characterize that more. Still a problem. And now we have ambient AI technology, which is essentially passive inputs, audio, and sensors to capture that audio input and bring it into our EHRs. We have ambient AI for nursing, and there have been great reports from pilots about this technology, particularly in the physician community. It's been said in several different publications that it's bringing the joy back to medicine. And I think it has this opportunity for nursing as well. Cedars-Sinai had a great pilot, and we highlighted it in a webinar through the 25x5 task force. The nurses overall really loved it. They showed that the HCAP scores actually improved. But something that we should recognize is that this technology is still working with, if you see in the upper left-hand corner, I put that network analysis back up there, the flow sheets, the really, wicked problem of flow sheets. And so we should reflect at this point in time that we don't want the engineering challenge of how to get this audio data captured through ambient technology into flow sheets to fall onto nurses, that they need to be speaking to it in a certain way, that they need to be kind of retrofitting it into these different flow sheet fields. Instead, recognize this is an engineering challenge that we need to do, and maybe flow sheets need to change. Maybe we need to be capturing voice to data and then coding that data on the other end for nurses, as opposed to saying, well, you need to kind of change your workflow a little bit because you really got to get it voice into the flow sheet structure here. So let's reflect on what we're really at and what our goals really should be here. Now, AI will likely force new documentation patterns for sure. This is something that I think, we should recognize. What's interesting is we had a study funded by AHRQ, and we found that when nurses were free to decide how to document during the COVID-19 pandemic, so it was actually by law, they only had to document medications. They didn't have to document anything else. They streamlined their charting to focus on information that drives care decisions and team communication and coordination, and they maintained consistent levels of essential clinical data capture. And we landed on essential clinical data capture through mixed methods to really show, this was the information nurses said was driving care decisions. And then also through some of our quantitative data, we're able to show that nurses still maintain that high level of documentation for the information that they deem matters for the patient care and the patient team. And so the way I see that is with AI, the nursing process still remains, and to reflect on the fact that the nursing process is not well captured in our EHR as it is today. And so with AI, hopefully we can resurface the nursing process in an even better way. The concern, early warning system models nurses' behaviors, and these nursing behaviors save patient lives. And so I think that we can imagine what nurses can do once the systems they're required to use are designed to support the nursing process and how they actually deliver care. And with these AI solutions, we really could start to leverage that. We need to be careful and make sure it's human-centered, but I think there's great opportunity. So in summary, we talked about the nursing perspectives on AI, knowing the arena to bring clarity to human-centered AI, some of the opportunities and risks of AI in terms of future agentic agents, and nursing surveillance that save lives. We need to protect that time for nurses, but I do have great optimism for the future of nursing practice data. We just need to do this right. One final quote in terms of the safety aspect, there are some reservations, but mostly I feel as if we're taking the right steps. We need to get the right people involved to make it safe and show the data that it is safe. It's going to take time for that to happen because within healthcare, we're affecting patients. It can be slow, but I find it very optimistic. Thank you.
Dr. Rossetti, this was an amazing talk. Thank you very much. We really, really appreciate it. It was an amazing talk. I learned a lot, and I'm sure the other people also appreciate it. And so I want to clap on behalf of everybody attending. So this was amazing. So I'd like to start by one question related to your concern study. I think it's just amazing. I had a renewed sense of appreciation for nurses and the care that they provide. I had never thought about just, it's an incredibly smart study. And I also appreciate how you involve the community just, through these surveys, and even for your studies, you have a poll to improve it. So I think this will be hopefully this will be a common practice among other scientists as well. For the concern study, I just downloaded when you were speaking the study. When I looked at the dates, it looks like you ran the study between 2020 and 2022, and we know that this is also the height of COVID.
We did. Yes.
It is amazing. And then, of course, this was, you showed us that there's similar results were obtained by other independent studies. I presume those were at different time periods. But do you want to comment a little bit on this, just, the impact of COVID potentially on this, as well as I was also curious to see if you looked at the level of experience of nurses, staffing ratios, and considering that this was during COVID, any impact of burnout levels on these studies?
Yeah, great questions. So yes, we conducted it during the COVID pandemic. We actually we knew going into February 2020 that we were not going to be going live at Columbia at that time. The reason is because we were just implementing Epic. So we actually had a planned delay, from the original timeline there. That was an interesting February into March and that spring, of course. But up at our Boston site, and the site PI up there is Patty Dykes. She's now at Emory, but man, she made it happen. The development, the installation had already occurred, and we were ready. And she really advocated to leadership that this may be a useful tool right now, in the context of what's happening. And so then we did go live, not in that spring, but it was in October of 2020. So, a bit after that initial moment of COVID. But we did, if you look at our Nature Medicine publication, we did do a sensitivity analysis for, COVID patients to make sure that wasn't skewing the results in any way, and it was not. We have in other capacities looked at this notion of nursing documentation patterns during COVID. And really what it showed is, even amidst this incredibly chaotic time, when we know nurses were highly burdened, ratios may not have been great, you were working in a new area possibly, nurses still maintained high levels of the documentation patterns that are drivers in our model. And so this is really nursing surveillance. So they're selecting this information that is informing the care team, informing care for that day, or possibly anticipating, the next several days of what do we really need to know about this patient and what are we really monitoring and making decisions about. And so that's why, I kind of wrap up my talk talking about, well, we have this huge change that's about to come. Maybe we won't be on flow sheets anymore. We're going to, we're not going to be manually entering data. We have ambient AI, we have generative technologies. I am so incredibly hopeful that, nurses have nursing practice and the nursing process that, that will maintain. And we just have to make sure that hopefully in this movement, our systems better support that and not just maintain status quo.
This is wonderful. Are there any other questions from the audience? If nobody asks, I have several other questions. This is fascinating, but let's also give our audience. Mary.
Hi, Sarah. Thanks. Your presentation was wonderful, as I knew it would. So, yes, I share the same idea as Dr. Gherkin in terms of the fact that, when we were going up in COVID, there was an awful lot of people traveling around, working in places that they weren't familiar with. And certainly, I think, we've seen that things are a little better now. But have you noticed that there are differences in, like there was a real big time where we've had just mainly a lot of new nurses and, traveling nurses, et cetera. And can you pick that out in the noise of the data that, it gets better as nurses get more accomplished in their roles?
Yeah, that is a really great question. And it is something we've discussed many times. Unfortunately, we don't have great data about that. The EHR doesn't actually have great data about the nurses'
that's characteristics.
And so it's pretty limited what you can infer from it. There can sometimes be, you can know when they were perhaps hired at that site, and that's if you've been on that EHR long enough, enough that there wasn't a switch over. So the data is just not that great, and we haven't done that analysis. Yeah.
Yeah. The rest of your ideas are really great, and certainly that whole concept of nurse surveillance is something that we really have to capture, because as you don't, we really need to protect what nurses are doing. So I'm totally on board with what you're talking about.
Great. Thank you. Thank you. Yeah.
We probably talk less about the burden on nurses than physicians. Just, the impact of documentation on physicians is incredibly well documented, and then whenever there is documentation burden, we mostly talk about how this is impacting physicians. And then when you go and see for 15 minutes your physician, they turn their back to you and then they are typing something on their screen. But people don't probably realize how much of a burden it is also for our nurses. And it may be because just nurses are, as always, very kind and caring. And that documentation is kind of hidden when they go back to their station and then they do it over there, not during the patient care. Maybe people don't realize it. Maybe we need to bring this challenge to the forefront and then hopefully address these with the help of AI. What do you think?
I agree without a doubt. There was a huge movement towards making nursing documentation almost all structured. And at some hospitals, say you don't even need to write your end of shift note anymore. And so this was kind of the wave of, okay, we're implementing EHRs and the EHR can now capture everything. We want to be able to compute on the data, so it needs to be structured. Of course, that's how we thought for so long. Now that's not necessarily the case. Now we can start to process data that is, captured in text. And so we have that opportunity to really reflect on how, data needs to be represented. But when it's all structured like that, what's amazing to me is that you actually see nurses nurses are so busy, and yet you see them taking the time to link up two structure concepts within the EHR. They will, if you have a patient that has an oxygen of 98% and it's been 98% all day, and you see a comment in there saying, well, patient was on 2 liters when I came on this morning, nasal cannula, and now they're on 6 liters. The nurse is taking that time to associate these structured fields that are not next to each other to say, guess what, that 98%, that's not real. They are not doing well. I've been upping the supplemental oxygen this whole time. Our EHRs do not convey that relationship. And so the fact that nurses take that time, I think, just speaks to, how we're not supporting the real work that they're doing. And that we're requiring that extra effort in their documentation. It seems like this is just how it always has been and how it always will be, but it really, there's no need for that. Our paper-based flow sheets, that was an easy thing to write in or put or circle in red. Easy. And that actually worked well for nurses. And then it was so visible. But we made our paper-based flow sheets computerized.
Yeah, we need a new level of thinking, right?
We've scaled past the usable part of them.
Wonderful. Thank you so much, Dr. Rossetti. And on your behalf, I again would like to congratulate all of our nurses and want to celebrate the Nurses Week. And nurses are very important for us. And hopefully we can use AI's help to make our nurses happier, a little bit more effective and comfortable. That's our goal. We will continue with this nursing AI series. We will have another speaker. We couldn't arrange the other speaker, Dr. Demiris from UPenn, to come talk this week, but there will be another nursing AI speaker, and then many others. If you have other suggestions, please let us know. And then thank you so much, Dr. Rossetti. Have a nice afternoon, everybody. Thanks for joining us this afternoon.
Thank you for
Bye-bye.
having me.